Okay, I emailed everybody. I could not get it posted on the module. It would not let me, kept giving me an error message. So I'll give everyone a minute. Okay. So this would be, can everybody see the screen share? It's like a black and white PDF.
Yes, I can see it.
Okay, good. All right, so just gonna go over some um, basically like a lung exam. Okay, so for starters, this is kind of visualize the lung field in the front of the chest area, and then here's the visualization in the posterior chest wall. Okay. All right, so I'm not going to get into a lot of detail on the history and how you talk to your patients and stuff like that. Um, this PDF that you're looking at is out of Bates. Okay, so Bates is a kind of a gold standard exam book, so guide to physical exam. Okay, so the quick version of, when a patient comes in, you have the subjective part, okay, subjective, which means the things that they tell you, and then you have the objective, which are the things that you find, okay? So this one gets into a lot of examples of going into that history with your patients and all the subjective things that can come with it. And you can ask leading questions, you can just let them talk, whatever it takes. Everybody's different, every patient's different. Some people will talk to you for hours and you're like, oh my goodness, how am I going to get this person to stop talking? And others, it just takes everything within inside of you to get information out of them, okay, and everything in between. So, but bottom line, taking your history is going to help you with that subjective. So they would tell you they have a history of coughing or shortness of breath, pain in their chest, okay, history of smoking. A lot of this is done either through the paperwork they filled out and or the way you talk to them, which is the interview, which all that is the history, okay? Are they spitting out blood? Okay, does it hurt to lay down? Hurt when they exercise? Okay, and so on. How long have they had it? So that's what all that gets into. Um, then so once you're done with the history, then you're going to get into the um, the actual exam. Okay, so in this case, we're going to listen to the chest, to the lungs, with your stethoscope. All right, so you're going to have um, it kind of doesn't matter where you start, the front or the back. Okay, the posterior chest or the anterior chest. Okay, so in this case, we'll just say you start in the back side. You'll want to um, if you notice here, you'll start at the top. Okay, and every time you place the stethoscope over their chest wall, you just have them take a deep breath in. And for me, I demonstrate and I show them the stethoscope and I say, every time I contact you with this, and I just show it to them, um, then please take a breath for me, and then I demonstrate. It's just a simple, okay, an in and out, deep breath. All right. So you'll start at the top, and as soon as you make contact, they'll breathe, and you go over, and then you go down. So you just follow these arrows, follow these numbers. Now this is to do a complete um, chest exam with the stethoscope. Now there's some shortcuts you can make, okay, but usually in a student clinical setting, you're going to do everything high end and everything perfect and by the books. And then once you become licensed, then you can learn to take all these shortcuts. Okay. So this was what a full one would look like. Start at the top. Okay. Then you go over, down, just to make sure you're getting uh, the entire lung field. And don't forget to go pretty far inferior and then pretty far lateral. Okay. What ends up happening is if people have fluid in the lungs and you take too many shortcuts, including not getting to that lateral part of the lung field, you might miss um, certain abnormal breath sounds. Okay. So just don't forget to make sure you get the entire lung field, posterior chest and anterior chest. Okay. So we give breath sounds a name. All right. So these are normal breath sounds. And they'll call it bronchial and then bronchovesicular and then vesicular. So these are just fancy names for normal breath sounds. Okay. Um, the bronchial, also known as tracheal, okay, this is going to be the loudest because you're right over the trachea. Okay, you're basically right in the midline of the person, right over the trachea, like right at the throat area. Okay, breath sounds are going to be very loud. Okay, the arrows represent the patient's the breath. So you have inhale and then exhale. Okay, inhale, then exhale, inhale, then exhale. So that first line there is the inhale part, and the second line is the exhale. So inhale, exhale, inhale, exhale. And if you were to graph the sounds, this is where they come from. So the inhale part is kind of short and not um, quite as doesn't really scream at you, but that exhale part is going to be long and loud and exaggerated, and you're going to hear it more. That's why the line is longer. Okay. On the bronchovesicular, the inhale and the exhale are about the same length and the same pitch. So the inspiration and expiration are the same as far as sound. Okay. Um, and then you're also a little bit more lateral on the chest wall. So if here's the trachea, okay, and then there's the lungs. So with bronchial, your stethoscope is like right there. All right. As you move farther away from the trachea, farther away from the tubes, the sound gets softer. All right. So bronchial is really loud. Okay. Bronchial vesicular means you're about there, starting to get a little bit more lateral away from the midline. And then vesicular, you're very wide. Okay, you're farther away from the midline, so it's going to be quieter, softer. All right. So one more time, the more midline you are, the louder it is. The more lateral you go away from the lung field, the softer the sound gets. All right. So bronchial would be very loud. Bronchial vesicular would be kind of a medium loudness, and then vesicular would be a quiet sound. Okay, and it depends on the location of your stethoscope in relation to that trachea. Okay, so bronchial is over the trachea, bronchiovesicular is over the bronchi where there's few alveoli. Okay, so you are lateral to the sternum, and then vesicular would be over the lung field. Okay, kind of more lateral on the thoracic cage or the lung field. Okay, this one shows you from the posterior what that would be. All right, so not a lot of bronchial from the posterior thoracic cage. Okay, it's going to be bronchiovesicular and vesicular because that trachea is in the front, right? It's in the throat area. It's obviously hard to get to that from the posterior thorax. So your sounds are going to be bronchiovesicular and vesicular from the posterior aspect. And you can see the BVs there and then all those Vs. So remember, the more lateral you go, okay, it's not going to be quite as harsh and loud as a sound. All right, so bronchiovesicular is this area, and then the remaining is going to be a vesicular sound. All right, from the front, over the actual airway, be that loud bronchial sound. Okay, and as you go just a touch lateral, bronchiovesicular, and as you go even more lateral, all your vesicular sounds. Okay. Also make sure you're using the diaphragm of the stethoscope, because there's usually two parts to the stethoscope. You have the bell and the diaphragm. Okay, the bell is usually the smaller surface area and the diaphragm is the bigger one. Okay, in most stethoscopes you can just simply turn to activate either the diaphragm side or the bell side. Okay, so the rest of this gets into doing an abdominal exam. All right, there's another um, handout. Here it is. Yeah, another handout I gave everyone. I think I posted, yeah, we posted this when we did heart. Okay, so it's on the module somewhere, probably, let me see. Maybe week 5. So if you can get a second and download that one, we'll go over a few more things. I'm checking on the module right now. What is this? Okay, do you guys see that? Or is that something I need to post? Oh, it's under week 4. Yeah, week 4 nursing guide, I think. Yeah, okay, so it's on week 4. It says nursing and Bates guide to auscultation and blood pressure. Okay, so on the lung field, which is over here, same thing. You can see the bronchial, vesicular, and vesicular. Okay. From this one, there's a few other things I want you to know from a clinical perspective, and that's the sounds. Okay. So with crackling, the characteristics is a popping, crackling, bubbling type sound. And then I also want you to know what that might indicate. And that is pneumonia, pulmonary edema, or pulmonary fibrosis. Okay. Rhonchi is a rumbling sound on expiration. Okay. Rumbling sound on expiration. The key word there is expiration. Think pneumonia. Actually, with just about any abnormal breath sound, always pneumonia is like a reoccurring theme through just about everything. Okay. So just always think pneumonia. And then you've got the other ones, right? Like emphysema, bronchitis, bronchiectasis, okay, pulmonary edema. But you're almost safe to assume with abnormal breath sounds they're dealing with some form of pneumonia. All right, so rhonchi, rumbling sound, expiration, think pneumonia, emphysema, bronchitis, or bronchiectasis. Okay, with wheezing, a high-pitched musical sound heard on both inspiration and expiration. Okay, you want to think emphysema, asthma, which is the big one, or a foreign body. Okay, I get a lot of those sounds with the asthmatics, and I've heard a few just over the years. I think I only had 2 cases of a foreign body. So that one for me is not common, but I have had a couple, and it does make a distinct high-pitched musical whistling sound. Okay, during the wheezing, especially with the foreign body. All right. So the friction rub. Okay, you're going to think an issue with the pleura, right? That parietal and visceral pleura and that pleural space. There is fluid in that pleural space. So you want to, if it's inflamed, so type of pleuritis or pleurisy, or pleural infarct, okay, you're going to hear a dry grating sound on both inspiration and expiration. To me, it sounds like 2 pieces of leather kind of rubbing together. Okay, the friction rub. Okay.